Let's begin. So here we were talking about the HPO axis, right? Hypothalamo-pituitary ovarian axis. So we have the follicle stimulating hormone and the luteinizing hormone acting on the granulosa and the theca cell respectively. Now the granulosa cell secretes estradiol and inhibin, okay? Mainly inhibin B, okay? And corpus luteum secretes which type of inhibin? Corpus luteum secretes, yes, corpus luteum secretes inhibin A. Corpus luteum secretes inhibin A, okay, under the influence of luteinizing hormone. In turn, what do these hormones do to the pituitary? These hormones inhibit the pituitary, right? We call that negative feedback inhibition, okay? These hormones inhibit the pituitary. We call them negative feedback inhibition. Negative feedback inhibition, right? So this is about HPO axis. So which pituitary hormone is mainly under the control of estradiol? The pituitary hormone that is mainly under the control of estradiol is FSH. The pituitary hormone which is mainly under the control of estradiol is FSH. Similarly, the pituitary hormone which is mainly under the control of androgen is LH. The pituitary hormone which is mainly under the control of androgen is luteinizing hormone. Fine. So this is about hypothalamo-pituitary ovarian axis. So coming to the functions of FSH, what all does FSH do? Point number 1, FSH helps in the multiplication of granulosa cells. FSH helps in the multiplication of granulosa cells. Multiplication of granulosa cells. Point number 2, FSH increases aromatase activity inside the granulosa cell. FSH increases aromatase activity in the granulosa cells, okay, thereby increasing estradiol synthesis, okay. Point number 3, FSH increases the size of the follicle, okay. FSH increases LH receptors. FSH increases LH receptors, okay, on the follicle, okay. So if only the follicle is primed by FSH, will the follicle respond to what? LH. You understand? So for the LH to act on the follicle, FSH priming is required. Now coming to the functions of luteinizing hormone. What does luteinizing hormone do? Point number 1, luteinizing hormone helps in the differentiation of stromal cells into theca cells. It helps in the differentiation of stromal cells into theca cells, okay. Point number 2, it helps in the final maturation of the follicle. It helps in the final maturation of follicle, converting the primary oocyte to secondary oocyte, and helps in ovulation, okay, and triggers ovulation. So which is the natural trigger for ovulation? Luteinizing hormone is the natural trigger for ovulation. Point number 3, LH supports corpus luteum. LH supports corpus luteum. It makes the corpus luteum secrete few important hormones, namely androgens, estrogen, and of course progesterone. Androgen, estrogen, progesterone, and inhibin A or B? Inhibin A or B? Inhibin A, okay. It helps the corpus luteum secrete inhibin A. These are the functions of luteinizing hormone. Fine. So we have few important functions for the follicular stimulating hormone and luteinizing hormone. All of these functions are very important and have to be remembered. Fine. Now coming to the normal duration of menstrual cycle. What is the normal duration of menstrual cycle? What is the normal duration of menstrual cycle? The normal duration of menstrual cycle is 28, 28, 21 to 35 is the older guideline, no? 28 plus or minus 7. Now it's 28 plus or minus 4. Okay, 28 plus or minus 4. So anything between 24 and 32 is normal. Okay, and day 1 of the cycle is the day she starts menstruating. Okay, day 1 of the cycle is the day she starts menstruating. Now with respect to ovulation, we divide the menstrual cycle into two halves, right? So the ovarian cycle is divided into follicular phase and luteal phase. Luteal phase. Okay, so why do we call the first half as follicular phase? Because that's when the follicle grows. And the second half is called as luteal phase because in the second half we have the corpus luteum functioning there. Okay, so follicular phase and the luteal phase. Now follicular phase and luteal phase are with respect to changes in the ovary. Now the same thing in the endometrium will be called proliferative and secretory. Okay, so the first half of the endometrial cycle is called as proliferative phase. And the second half is called as secretory phase. The first half is called as proliferative phase and the second half is called as secretory phase. Proliferative and secretory. Okay, now out of these two phases of the menstrual cycle, tell me which half is constant and which half is variable. Follicular versus luteal. Follicular versus luteal. Which half is constant? Yes? Luteal phase is constant. Very good. Luteal phase is constant, and also remember luteal phase is always by 14 days. Luteal phase is constant and it is always by 14 days. It is always by 14 days. You all understand? It's constant and is always by 14 days. Okay, so whenever there is a change in the duration of the menstrual cycle, it will usually be due to the change in the follicular phase and not the luteal phase. For example, tell me, in case of a 28-day cycle, when does ovulation usually occur? In case of a 28-day cycle, when does ovulation usually occur? 14th day, no? Yes, ovulation occurs on day 14. Ovulation occurs on day 14. In a 24-day cycle? In a 24-day cycle, when does it occur? Day 10, very good. In a 24-day cycle, it occurs on day 10. In a 30-day cycle, it is day 16. Day 16, correct. And in a 32-day cycle, it is day 18, which means minus 14. Minus 14, minus 14. You understand? This is the day of ovulation. Okay. Now, the second half of the menstrual cycle is always constant. That's because the lifespan of the corpus luteum is constant. Lifespan of the corpus luteum is constant and it is always by 14 days. You all understand? No, the lifespan of corpus luteum is constant and it is always by 14 days. Okay. Fine. So now coming to few important questions on the follicular phase and the luteal phase. Is physiology done for you all? Is physiology done? Okay. So you must be knowing all of these. Okay. Fine. The first question is, listen to me first and then you can answer the questions on the workbooks. Okay, listen to me first. Okay, now what happens in a normal menstrual cycle is that in a menstrual cycle, as you all know, day 1 of the menstrual cycle is the day she starts ovulating, right? Most of the points are printed, so just listen to me, you can copy later. Okay, day 1 of the menstrual cycle is the day she starts her menses. Okay, so bleeding starts here. Bleeding starts here. Okay, now why does bleeding begin? The most important trigger for bleeding is a fall in estrogen and progesterone, right? The most important trigger, okay, the most important event that triggers bleeding is a decrease in estrogen and progesterone. Decrease in estrogen and progesterone. Fine. Now, as estrogen and progesterone decreases, what happens? A very important hormone which was under the feedback inhibitory loop of estrogen now starts increasing. And which hormone is that? Yes, a very important hormone which was under the inhibitory effect of estrogen now starts increasing. Very good, that's FSH. So FSH starts increasing here. Okay, as FSH starts increasing, FSH actually starts increasing on the 26th day of the previous cycle. Here is where FSH starts increasing. Okay, on the 26th day of the previous cycle, which means 2 days prior to the onset of menses. As FSH starts increasing, it starts recruiting all the follicles, no? It starts recruiting follicles. So follicle now grows. Follicle gradually grows and at one point reaches its peak size. And at one point reaches its peak size. Now, under the influence of FSH, follicle secretes something. What does it secrete? Under the influence of estrogen, FSH, follicle secretes estradiol, right? Follicle secretes estradiol, okay? So estradiol keeps increasing now. Estradiol keeps increasing and at one point estradiol reaches its peak. Okay, and at one point what happens? Estradiol reaches its peak. Okay, so let's say this is the day of E2 peak. This is the day of E2 peak. Okay, now the follicle, let's say, has reached a size of 20 mm. The follicle has reached a size of 20 mm and now it's ready for rupture. Ready for rupture. Estradiol peak triggers something. Yes, triggers something which is required for the follicle to mature and finally rupture. Okay, which hormone helps in the final maturation of the follicle and rupture of the follicle? LH. Very good, very good. LH. So LH starts increasing here. LH starts increasing here and that event is called as LH surge, as you all know. Okay, that event is called as LH surge, and let's say this is day 14 and this is where ovulation occurs. This is where ovulation occurs. Okay, now tell me, yes, LH, so this is day 14, no, where LH surge, by the day, by the time LH, ovulation occurs, LH would have already reached its peak and already would have come to the bottom line again. Okay, so LH increases and then doesn't stay in the peak for a longer time. It stays in the peak for a very short time. It stays in the peak for a very short time, only to immediately fall. And by the time it falls, no, ovulation occurs. You understand? My question is, estrogen actually, inhibits the pituitary, as you all know. Okay. So now here I am telling, prior to ovulation, LH increases. Will only LH increase or FSH also increase? What's your opinion? Will only LH increase or FSH also increase prior to ovulation? Is there anything called FSH surge? FSH also. There's something called FSH surge. Very good. There's something called FSH surge. So FSH also increases. We don't talk much about FSH surge because when compared to the magnitude of LH surge, the magnitude of FSH surge is very small. Okay. So we don't talk much about FSH surge, but FSH also increases. Okay. Estrogen is supposed to inhibit the pituitary. No, I'm telling you, estrogen already reaches its peak, but still FSH and LH manage to increase instead of getting inhibited. How? Yes. Estrogen inhibits the pituitary, and when estrogen has already reached its peak, LH and FSH are supposed to get inhibited, no? Yes. How does LH and FSH increase here? That is because the negative feedback effect of estrogen on the pituitary, okay, is converted to a positive feedback effect after estrogen reaches its peak. Okay, the negative feedback effect is there, but it will at one point change to positive feedback effect. Okay, it will at one point change to positive feedback effect. Okay, so what will happen? As estradiol reaches its peak, it starts, estrogen peak triggers LH surge. Estrogen peak triggers LH surge. Okay, so it triggers LH surge. Okay, so it is estradiol peak that triggers FSH and LH surge. Okay, so let's say ovulation occurs here. After ovulation, the follicle will now be converted into a corpus luteum, right? The corpus luteum will start secreting three important hormones, including inhibin, but two important sex steroids, one is estrogen and the other one is progesterone. Okay, so what happens? They increase and then stay in the plateau phase for a while and then decrease. Okay, stay in the plateau phase for a while and then decrease. Okay, so estradiol and progesterone, estradiol and progesterone. So when they start falling, FSH increases. When these two hormones start falling, no, FSH increases. So when does FSH start increasing? Tell me. When does FSH start increasing? Low concentrations, negative. Yeah, correct. Correct. Okay. So you tell me, no, when does FSH start increasing? Day 26. Okay, FSH starts increasing on the 26th day of the previous cycle. Okay, previous cycle, which is going to help the follicles grow in the next cycle. Okay, which is going to help the follicles grow in the next cycle, because in between she'll get her periods, no? Okay, so this is how things go. Okay, now few important questions here. Okay, question number 1. The first hormone to increase in a normal menstrual cycle is. So by now you will be thorough with the answer, right? The first hormone to increase in a normal cycle is FSH. Okay, the first hormone to increase in a normal cycle is FSH. Okay, the second question is, what is the size of the dominant follicle on the day of ovulation? The average value is 20 mm. Okay, the average value is what? 20 mm. Okay, next question is, when does LH surge begin and when does it reach its peak? Okay, question is, what is the time gap between LH surge and ovulation? What is the time gap between LH surge and ovulation? And what is the, yes, 36 hours. Correct, 36 hours. What is the time gap between LH peak and ovulation? What is the time gap? This is 36 hours. What is the time gap between LH peak and ovulation? Excellent answer, Janani. 12 hours. Okay. The time gap between LH surge and ovulation is 36 hours. The time gap between LH surge and ovulation is 36 hours. So LH surge begins 36 hours before ovulation and LH peaks 12 hours prior to ovulation, and that is when LH also appears in the urine. So we have ready-made kits which the patient can use at home, like how we have HCG kits, we also have LH kits. So whenever the LH kit is positive, it means her LH has appeared in the urine, which means in the next 12 hours she is going to ovulate. Okay, next question is, what is the serum level of estradiol prior to ovulation? It is 200 to 300 picogram per ml per follicle. 200 to 300 picogram per ml per follicle. Next is, ovulation occurs as a result of increase in what all? Ovulation occurs as a result of increase in estradiol, FSH and LH. Ovulation occurs as a result of increase in estradiol, FSH and LH. Okay, see this graph, all of you. Now 2 years ago we had one such graph in PG, and one particular hormone was marked and you were asked to identify the hormone. Okay, so now see this. There is one hormone here which is very low in the initial phase of the menstrual cycle, which is marked in red here, which is low in the initial phase of the menstrual cycle. Okay, and then increases on day 6 of the menstrual cycle, and this is the first hormone to reach its peak. First hormone to reach its peak. What is that? The hormone that reaches its peak before any other hormone could reach its peak. Estradiol. Very good. This is estradiol. The pink one is estradiol. Okay, the red one is estradiol. Okay, next is, there is another hormone, okay, which reaches its peak in the middle of the menstrual cycle. Listen to me, reaches its peak in the middle of the menstrual cycle, whose amplitude is bigger than any other hormone. In fact, the biggest, the tallest. Which one? Whose amplitude is the magnitude is the largest or the biggest? LH. LH, correct. So this dotted black one is LH. This dotted black one is LH. There's another hormone which is the first one to increase. In fact, it increases prior to the onset of menses. So you can see here, it increases prior to the onset of menses, and this hormone also increases, reaches its peak in the middle of the menstrual cycle, but not as big as LH, not as big as LH, and that is FSH. Correct, that is FSH. This blue one is FSH, and one hormone remains silent throughout and increases only in the second half. Increases only in the second half. What is that? Progesterone. Perfect answer. Progesterone. So now you understand how to identify, no? Yes, how to read this graph. Estradiol, LH, FSH and progesterone. Okay. So what happens after ovulation? After ovulation, the Graafian follicle collapses and there is deposition of lipids and pigments. Okay, there is deposition of lipids, okay, and pigments. One important pigment that is deposited in the corpus luteum is called as lutein. Okay, so it's basically a pigment called lutein. Okay, it's basically a pigment called lutein. Okay, and because there is deposition of lutein, which is an yellow pigment, we call this structure as corpus luteum. So the word corpus luteum comes from this pigment called lutein. Okay, the word corpus luteum comes from this pigment called lutein, which is yellow in color. Okay, and because in the non-pregnant state, who supports the corpus luteum? LH supports the corpus luteum. Because this hormone supports this corpus luteum in the non-pregnant state, we call it luteinizing hormone. Luteinizing hormone. Okay, because it supports corpus luteum, we call it luteinizing hormone. So for how long will it work? It will work only for 14 days. Okay, it will work only for 14 days, this corpus luteum. Now if pregnancy does not occur, okay, corpus luteum will degenerate. If pregnancy does not occur, corpus luteum will degenerate, and that is what is called as corpus albicans. Okay, if pregnancy does not occur, corpus luteum will degenerate, and that's called as corpus albicans. If pregnancy occurs, this corpus luteum will continue to work. This corpus luteum will continue to work with the help of HCG. Okay, with the help of which hormone? HCG. Okay, so HCG functions like LH and now supports corpus luteal function. Is it okay? So this is about luteal phase. Okay, so what all does the corpus luteum secrete? Corpus luteum secretes three important hormones. One is estradiol, the second is progesterone, and the third is inhibin A. Okay, estradiol, progesterone and inhibin A. Okay, next question is, when is the corpus luteal activity maximum? Maximum activity of corpus luteum is in a non-pregnant cycle is on the 8th day post ovulation, which is a 22nd day of the menstrual cycle. Day 8 post ovulation. Day 8 post ovulation, which is 22nd day of the menstrual cycle. 22nd day of the menstrual cycle. Next is, when is the corpus luteal activity maximum? During pregnancy. It is 8 weeks of pregnancy. 8 weeks of pregnancy. Okay, so please remember, in the non-pregnant state, the maximum corpus luteal activity is seen on day 8 post ovulation, and during pregnancy it is seen at the 8th week, okay, post ovulation. Okay, next is, when does it stop functioning? Corpus luteum stops functioning. You tell me the answer. No? Yes? When does corpus luteal activity cease? When does corpus luteal activity cease? No, 12 weeks. No, during pregnancy. During pregnancy. When does corpus luteal activity cease? Okay, 12 weeks. Corpus luteal function ceases completely and placenta takes over by 12 weeks. 12 weeks. Okay. Next question is, serum level of progesterone prior to ovulation. Serum level of progesterone prior to ovulation is less than 4 nanogram per ml. Okay, what was the unit for estradiol? I told you. The unit for estradiol was picogram. And the unit here is nanogram. Okay, the unit here is nanogram. It's less than 4 nanogram per ml. And after ovulation, it is 4 to 40 nanogram per ml. After ovulation, it is 4 to 40 nanogram per ml. Okay, the last question on menstrual cycle is the first sign of secretory change in a menstrual cycle. The first sign of secretory change in a menstrual cycle is basal vacuolation. I'll tell you what is basal vacuolation later. For now, just write the first sign of secretory change in endometrium is basal vacuolation. And when does basal vacuolation occur? It appears 4 days post ovulation. Okay, basal vacuolation appears 4 days post ovulation, which is day 18 of the menstrual cycle, which is day 18 of the menstrual cycle. Okay, 4 days post ovulation, which is day 18 of the menstrual cycle. You all understand? Okay, so these are the questions on menstrual cycle. Okay, so corpus luteum secretes estradiol, progesterone and inhibin A. Peak activity of corpus luteum in a non-pregnant cycle is 8th day, and during pregnancy it's 8th week, and it completely stops functioning by 12 weeks. Serum progesterone before ovulation is less than 4 nanogram per ml, and after ovulation is 4 to 40. The first sign of secretory change is basal vacuolation, which appears on the 4th day post ovulation. Okay, so this is about MCQs on them. So do you all know what is corkscrew gland? Corkscrew gland. Corkscrew glands are nothing but corkscrew glands, and vessels also are nothing but dilated endometrial vessels and glands. Okay, they are nothing but dilated endometrial glands and vessels. And this dilatation is due to which hormone? Yes, this dilatation is due to which hormone? Correct, progesterone. It is due to progesterone. Okay, coiled, correct. Okay, so if the endometrial gland is something like this in the pre-ovulatory phase, what will happen to this? It will become something like this in the post-ovulatory phase. In the post-ovulatory phase. Okay, and this corkscrewing is a sign of ovulation. Okay, this corkscrewing is a sign of what? Ovulation. Corkscrewing is a sign of ovulation. Is it okay? So these are the questions on the proliferative and the luteal phase of the menstrual cycle. Okay, now coming to layers of the endometrium. Okay, layers of the endometrium. Okay, I already told you this when we discussed obstetrics. Once again, I'll tell you here. We have 3 layers in the endometrium. They are superficial compact layer, superficial compact layer, intermediate spongy layer, intermediate spongy layer, and deep basal layer. Superficial compact layer, intermediate spongy layer, and deep basal layer. Superficial compact and intermediate spongy together make the functional layers. Together make the functional layers. Okay, and deep basal layer is the reservoir. Deep basal layer is the reservoir from which the endometrium regenerates after menses. Okay, endometrium regenerates. Okay, endometrium regenerates. Okay, after menses from the deep basal layer. Okay, fine. Now coming to the blood vessels. Blood vessels. Okay, what is the order of branching of uterine artery? Uterine artery. Okay, uterine, as you all know, uterine artery is the artery that supplies the uterus. Uterine artery first divides into ascending and descending branch, right? Descending branch becomes the descending cervical artery and then becomes the vaginal artery. Ascending branch becomes, okay, ascending branch further divides into segmental or arcuate artery. Segmental or arcuate artery, which later divides into radial artery, from which comes basal artery, from which finally comes spiral artery. Okay, segmental arcuate, from which comes radial and then comes basal, finally comes what? Spiral artery. Okay, now see, let's say this is the uterus. Okay, this is the endometrium. Now I am completing the endometrium here. Okay, let's say this is the serosa. Okay, this is the serosa and this is the outer wall of the uterus. Let's say it's like this, and here is the cervix. Okay, now you see some layers of the endometrium. No, here. Okay, this is myometrium. What you see deep inside is myometrium. Okay, myometrium. Fine. Now after the myometrium comes endometrium. Okay, and endometrium is further divided into functional layers and reservoir layer. Okay, now out of the 4 different arteries that we have studied, which artery supplies the functional layer, something that sheds and regrows along with the endometrium? Which artery is supplies the functional layer, I'm asking? Spiral artery. Very good, Emmanuel. Very good. Okay, spiral artery supplies the functional layers, which means, okay, the superficial compact and the intermediate spongy. Okay, basal artery supplies the basal layers. Arcuate and the radial supply the myometrium. Okay, arcuate and radial supply the myometrium. Okay, now I would say here is the basal artery. No, see the image? Here is the basal artery. No, yes, this is the basal layer of the endometrium. Okay, I would say this is the basal layer of the endometrium. Which is nothing but the reservoir layer which is supplied by the basal artery in this given image. Okay, beyond the basal layer, this is the uterine cavity. Now I am just completing the circle. This is the uterine cavity. Okay, this is the uterine cavity. Okay, here is the functional layer which I am shading with blue. Here is the functional layer which I am shading with blue, which is lined by the spiral artery, which is supplied by the spiral artery. Okay, so this is the functional layer which is supplied by the spiral artery, and then the basal layer which is supplied by the basal artery. Beyond that you have the myometrium. Which is supplied by the segmental arcuate and the radial arteries. You all understand, no? Yes? Okay, so this is about the arterial supply to the uterus. Okay, this is about the arterial supply to the uterus, the branches of the uterine artery. Okay, now coming to endometrial thickness. Okay, I'll finish this and give you a break. Okay, now coming to endometrial thickness. Okay, what is the endometrial thickness on day 2 of the menstrual cycle? Endometrial thickness on day 2 of the menstrual cycle. Endometrial thickness on day 12 of the menstrual cycle. Endometrial thickness on day 2 of the menstrual cycle is just 1 to 2 millimeter, whereas on day 12 of the menstrual cycle it is 10 to 12 millimeter. On day 2 of the menstrual cycle it's 1 to 2. On day 12 of the menstrual cycle it is 10 to 12 millimeter. Okay, and which hormone helps in the proliferation of endometrium? Name the hormone that helps in the proliferation of endometrium. The hormone that helps in the increasing the endometrial thickness? Estradiol. Very good. Okay, and this increase is mainly due to increase in estradiol. Okay, this increase is mainly due to increase in which hormone? It's because of the increase in estradiol. It's mainly because of increase in estradiol. Okay, next is luteal phase. In the luteal phase you also have progesterone, no? You also have progesterone along with estrogen. Okay, what is the effect of progesterone on the endometrium? Will it thicken the endometrium or thin out the endometrium? What will it do? What will it do? Will it thicken the endometrium or make the endometrium thin? Yes, progesterone opposes estrogen wherever possible. No, progesterone does not make the endometrium thick. Progesterone makes the endometrium thin. You understand why? Because progesterone opposes estrogen in the endometrium. Okay, progesterone opposes estrogen in the endometrium. You understand? Progesterone downregulates estrogen receptors. Okay, so the endometrium shrinks a little. In the luteal phase, endometrium becomes compact. Endometrium shrinks. That's called as compaction. Okay, and it drops to 8 mm. Endometrial thickness drops to 8 mm, and that is called as compaction. That is called as compaction, and this compaction is actually required for the endometrium to prepare itself for implantation. You understand? This compaction is actually needed to open the implantation window. Okay, next is postmenopause. After menopause, remember we have two cutoff. One is for women on HRT and the other one is for women not on HRT. Okay, so what is the endometrial cutoff for a postmenopausal lady? Endometrial cutoff for a postmenopausal lady? Yes, very good. 4 mm. 4 mm, correct answer. Okay, for a lady who is not on HRT, no HRT, the cutoff is 4 mm. Anything more than 4 mm is abnormal. Anything more than 4 mm is abnormal. For a lady who is on HRT, the cutoff is 5 mm. Okay, for a lady who is on HRT, the cutoff is 5 mm. So this is about endometrial thickness in different parts of the menstrual, different phases of the menstrual cycle and a postmenopausal lady. Hope you all understand. Yes, this is about the endometrial thickness. Is it okay? So it's 5:20 now. Let us stop here. Let us take a break of 15 minutes and then start by 5:35. We'll continue with few more important points on menstrual cycle, the functions of estrogen, progesterone, and this topic will take another maybe half an hour to finish. Okay, we'll finish this topic. Today we'll also discuss Mullerian anomalies. Okay, after menstrual cycle we'll also discuss Mullerian anomalies, so we'll have class till 8 o'clock today. Okay, right. Now coming to the functions of estrogen and progesterone, this is a very important MCQ area. The first thing is ferning. What is ferning? Cervical mucus. Okay, what happens to this cervical mucus under the influence of estrogen? What does estrogen do to the cervical mucus? Estrogen makes the cervical mucus thin and watery. Estrogen adds salt and water. Estrogen adds salt and water to the cervical mucus, thereby making it thin and watery. So when you place a drop of cervical mucus, okay, on a glass slide and allow it to dry, the salts will precipitate because there is more salt, no? Yes, on drying, what will happen? Salts precipitate. On drying, salts precipitate, and that is what leads to this fern-like pattern called ferning. So ferning is basically due to which hormone? Estrogen. Now what is spin bucket? Spin bucket is nothing but stretchability. Okay, spin bucket is nothing but stretchability of the cervix mucus. Okay, stretchability of the cervical mucus. Again, a thin mucus is stretchable. Thin mucus is stretchable. Okay, thick mucus will break on stretching. Thick mucus will break on stretching. You all understand? So what is this due to spin bucket? Due to spin bucket is again due to estrogen. Okay, ferning is due to estrogen. Spin bucket is also due to estrogen. Okay, now what happens to the cervical mucus on exposure to progesterone? Progesterone makes the cervical mucus thick. Progesterone decreases the water content. Progesterone decreases the water content and increases the protein content. Makes the cervical mucus thick. Okay, makes the cervical mucus thick. Okay, so this is called as TAC. The thick cervical mucus due to estrogen is called as what? TAC. TAC is the thick cervical mucus, okay, which is due to estrogen. So what will happen to ferning and spin bucket after ovulation? After ovulation, progesterone comes. No, that's when it doesn't allow the estrogen to work. Progesterone basically down regulates estrogen receptors in the genital tract, not in other parts, but in the genital tract. Okay, so you have to remember that point. Okay, progesterone down regulates estrogen receptors in the genital tract. Okay, so it opposes estrogen in the genital tract by down regulating its receptors. So all the estrogenic effects will disappear after progesterone comes. Okay, so it makes the cervical mucus thick. What will happen to ferning and spin bucket? Ferning and spin bucket will disappear. Ferning and spin bucket will disappear after ovulation. Okay, spin bucket will disappear after ovulation. Okay, now coming to maturation index. So this is about cervical mucus. I think you all are clear. Now coming to maturation index. What is maturation index? Maturation index is a study to see what all cells are there or which cell is predominantly seen in the vagina. Maturation index is vaginal hormonal study. Maturation index is nothing but vaginal hormonal study. Okay, how is it done? It's done based on the hormonal dependency of vaginal cells. So how many layers of epithelium do we have in the vagina? We have 4 layers. They are superficial, intermediate, parabasal and basal. Okay, we have 4 layers, namely superficial, intermediate, parabasal and basal. So which hormone does superficial cell depend on? Superficial cells depend on estrogen. Intermediate cells depend on progesterone, and parabasal and basal cells are hormone independent. Okay, superficial depends on estrogen, intermediate depends on progesterone, parabasal and basal are hormone independent. Okay, so what happens is that when a lady has plenty of estrogen in the body, mainly superficial cells are seen in the vaginal mucosa. When she has plenty of progesterone, mainly intermediate cells are seen. And when the body is devoid of both estrogen and progesterone, parabasal and basal cells are seen. You understand? So what we do is, we take a smear from the vagina. From which wall of the vagina? We take a smear from which wall of the vagina? Yes, lateral wall. Very good. Okay, we take a smear from the lateral wall of the vagina. And after staining it, we count the number of superficial cells, number of intermediate cells and number of parabasal and basal cells. You all understand? We count the number of superficial, intermediate, totally we count 100 cells. Okay, totally we count how many cells? 100 cells, and in that 100, we'll see how many superficial are there, how many intermediate and how many parabasal and basal are there, and we mark it in a grid. Okay, we mark it in a grid. The grid will have 3 columns. The grid will have 3 columns. The first column is for parabasal and basal. Remember, the first column is for parabasal and basal. The second column is for intermediate and the third column is for superficial, and the total number will be 100. Total number is 100. You understand? So it's just like making a percentage. Okay. So now I have given you 3 examples. I've given you 3 examples here. It's just a printing error, typing error. Okay, now I request you to change the first one to 92 and the last one to 3 here. Okay, so change it to 92 bar 5 bar 3. 92 bar 5 bar 3. Okay, so which cell is predominantly seen here? It is parabasal and basal. Okay, when you have plenty of parabasal and basal, what does that indicate? It indicates the absence of estrogen and progesterone, right? Tell me examples for this condition where parabasal and basal are predominantly seen, or when, very good, menopause. Menopause. Okay. If ovary fails after the age of 40, you call it menopause. If ovary fails before the age of 40, what will you call it as? If ovary fails before the age of 40, what will you call it as? Pre-puberty. We call it premature ovarian failure. Perfect answer. Premature ovarian failure. Okay. And also during menses, it will be like this. I mean, just prior to menses or during menses, it will be like this. Okay. Estrogen and progesterone deficiency. One other estrogen progesterone deficient state in the body. One other important physiological estrogen progesterone deficient state in the body. Yes? One other important physiological estrogen progesterone deficient state in the body, and that estrogen progesterone deficiency, very good, postpartum, is due to prolactin. When prolactin levels are high, pituitary doesn't work. Okay, pituitary doesn't work. When prolactin levels are high, hypothalamus doesn't work, pituitary doesn't work, because prolactin inhibits GnRH. Okay, so the examples for the first grid are, as you all said, menopause, premature ovarian failure, postpartum, okay, lactation, okay, post-abortion, and during menses. Okay, see the second grid. In the second grid, you mainly have intermediate cells, right? In the second grid, you mainly have intermediate cells. Tell me examples for the second grid. Post-ovulation, very good, which means luteal phase of the menstrual cycle. Very good. Pregnancy. Okay, and apart from pregnancy, there's one important drug which works like pregnancy, which inhibits ovulation, which prevents pregnancy, and the body by all possible means mimics pregnancy. Which drug am I talking about? A drug. Combined oral contraceptive. Excellent answer. Combined oral contraceptive. Very good. Okay, this combined oral contraceptive is also called as pseudo pregnancy drug. Combined oral contraceptive is also called as pseudo pregnancy drug. Okay, so these are the differential diagnosis for intermediate predominance. Please change the last grid to 2 bar 4 bar 94. 2 bar 4 bar 94. Okay, tell me examples now. Yes, 2 bar 4 bar 94. Predominantly, what do you see? Secretory phase. Is it secretory phase or follicular phase or proliferative phase? Okay, it's follicular phase. Okay, it is follicular phase of the menstrual cycle. Okay, tell me one important pathological condition in which the woman has an extended follicular phase. She doesn't go into the luteal phase at all. She doesn't ovulate. She doesn't go into the luteal phase. Follicular phase continues. PCOS, very good. Polycystic ovarian syndrome, high estrogen state. She'll not ovulate. Okay, PCOS. The third important differential diagnosis for this condition is metropathia hemorrhagica. I'll explain what is metropathia hemorrhagica later. But remember, metropathia hemorrhagica is an anovulatory condition. Metropathia hemorrhagica is an anovulatory condition in which the woman does not ovulate. She has high estrogen, prolonged follicular phase. Prolonged follicular phase. Okay. So these are the differential diagnoses for maturation index as mentioned here. Okay. Coming to pH of the vagina. Which hormone is responsible for the acidic pH of the vagina? The hormone that is responsible for acidic pH of the vagina? Yes? What does estrogen do? Very good, very good. Estrogen. Okay, what does estrogen do? Estrogen helps in deposition of glycogen. Estrogen helps in deposition of glycogen in the vagina. It helps in deposition of glycogen in the vagina. Okay. And this glycogen attracts a bacilli called lactobacilli. It attracts a bacilli called lactobacilli, which is also called as Doder-Lean bacillus. Which is also called as Doder-Lean bacillus. Okay. So this lactobacillus, okay, it attracts lactobacillus, and this lactobacillus converts glycogen to lactic acid. It converts glycogen to lactic acid, which makes the vaginal mucosa acidic. Okay, so vagina becomes acidic. Okay, pH decreases, vagina becomes acidic. Okay, so what is the normal pH of the vagina in the reproductive age group? The normal pH of the vagina in the reproductive age group is 4.5 to 5.5. 4.5 to 5.5. In the pre-pubertal age group, it's around 6 to 7. It's around 6 to 7. After menopause, it is more than 7. After menopause, it is more than 7. Okay. Pregnancy is a high estrogen state or a low estrogen state? Tell me. Pregnancy is a high estrogen state or a low estrogen state? Very good. High estrogen state. Very good. Pregnancy is a high estrogen state. So what will happen to a pregnant lady's vagina? It will become more acidic, no? Yes. So what will happen to the pH during pregnancy? pH high or low? Very good. It decreases. pH decreases during pregnancy to 3.5 to 4.5. And because a newborn gets all her hormones from the mother, a newborn's serum estradiol levels will be as high as her mother. Okay, so a newborn's vagina is also acidic only for the first 2 weeks of life. Only for the first 2 weeks of life. You understand? No? Yes? So the pH is 4.5 to 5.5 during the reproductive age group, 6 to 7 in the pre-pubertal age group. After menopause, it's more than 7. Pregnancy and newborn, it's 3.5 to 4.5. Okay, so this is about vaginal pH. Next, we'll move on to other functions of estrogen and progesterone. Other functions of estrogen and progesterone. Number 1 is on the endometrium. What does estrogen do to the endometrium? Estrogen helps the endometrial glands grow. Estrogen helps the endometrial glands grow. For example, if the endometrium is like this, without estrogen, the endometrial glands will proliferate. Okay, the endometrial glands will proliferate. For example, say this is the endometrial gland and this is the endometrial blood vessels. Okay, after menses, if it is this small, what will estrogen do? Once estrogen comes, okay, the endometrium starts growing, okay, and the blood vessels elongate. The glands dilate, become tortuous. Okay, they coil. They start coiling and the blood vessels dilate. This is, elongate. I'm sorry. Okay, the endometrium grows and the glands become bigger and the blood vessels grow and elongate with the help of estrogen. Okay, so what will happen to the overall endometrial thickness? Endometrial thickness increases. Endometrial thickness increases with the help of estrogen. And estrogen not only helps in elongation of the endometrial glands and the blood vessels, but also helps in mucin synthesis. Okay, it also helps in mucin synthesis, but that mucin will now only be in the apical portion of the gland and not in the basal portion. It will only be in the apical portion of the gland and not in the basal portion. Okay, now what does progesterone do? Now let's say this is the endometrial gland. This is the endometrial gland. With the help of progesterone, the glands coil and the blood vessels elongate and dilate. Blood vessels now elongate and dilate. Okay, let's say this is the endometrial cavity. This is the endometrial cavity. What does progesterone do? Progesterone mobilizes the mucus from the apical portion to the basal portion. Okay, so when you see it under the microscope, you will be able to see the vacuoles, okay, which is nothing but mucin filled pockets in the basal portion of the gland. Okay, so this is what is called as basal vacuolation. This is what is called as basal vacuolation, which appears on the 4th day post ovulation. Okay, so this is what is called a secretory action. Secretion means it is actually estrogen that helps in the synthesis of mucus. So progesterone only mobilizes the mucus from the apical to the basal portion of the gland, and that is why progesterone is called as secretory hormone. Okay, so what all does progesterone do? Progesterone helps in secretion. Point number 1, progesterone helps in secretion of the mucus. Point number 2, progesterone helps in dilatation of the blood vessels. Okay, dilatation of the blood vessels. And what does progesterone do to the endometrial thickness? Tell me. What does progesterone do to the endometrial thickness? Does it increase the endometrial thickness or decrease the endometrial thickness? Very good. Compaction or thinning. Okay, progesterone decreases the endometrial thickness. Okay, progesterone decreases the endometrial thickness, and that is called as compaction. Okay, so now tell me, can progesterone work in an estrogen, in an endometrium which is not primed by estrogen? You understand my question? Progesterone, can it work in an endometrium which is not primed by estrogen? No, it cannot work in an endometrium which is not primed by estrogen, because estrogen increases progesterone receptors. Okay, estrogen increases progesterone receptors. Okay, whereas progesterone downregulates estrogen receptors. Okay, progesterone downregulates estrogen receptors. You all understand? Fine. Now coming to myometrium. Myometrium. Okay. Now tell me, what does estrogen do to the myometrial thickness? Estrogen helps in the growth of the myometrium, or estrogen shrinks the myometrium? Yes, what does it do? Myometrium. Estrogen helps in the growth of the myometrium. Okay, what does progesterone do? Progesterone do. Estrogen helps the myometrium grow. Okay, increases the thickness. Increases the thickness. So estrogen helps the fibroid grow. Okay, estrogen increases the size of the fibroid. Estrogen increases the size of the fibroid. Estrogen increases the contractility. Estrogen increases the contractility. What does progesterone do to the myometrial thickness and fibroids? Tell me. What does progesterone do to the myometrial thickness and fibroids? Yes? No change. You mean to say progesterone has no effect on the myometrial thickness? It has no effect on the size of the fibroid? Increase. Which is the main growth factor for the fibroid? Answer my question. No. Which is the main growth factor for the fibroid? Estrogen or progesterone? Just tell me EP. Just tell me EP. My question is, which is the main growth factor? Which hormone is the main growth factor for fibroid? Estrogen or progesterone? The main growth factor for fibroid is progesterone. You understand? The main growth factor for fibroid is progesterone. Okay, I know most of you will be surprised. Okay, so unlearn the older one and learn what I'm telling now. Progesterone increases the myometrial thickness much more than what estrogen does. Progesterone increases the myometrial thickness much more than what estrogen does. Progesterone increases the size of the fibroids. Okay, progesterone increases the size of the fibroids more than estrogen. The main growth factor for fibroid is progesterone. Okay, estrogen also helps. How does estrogen help? By making the uterus more sensitive to progesterone, because estrogen increases progesterone receptors. Okay, contractility, again progesterone, no, when it comes to contractility they have opposite effects. Estrogen increases the contractility, whereas progesterone relaxes the uterus, because progesterone is basically a smooth muscle relaxant. Okay, progesterone is a smooth muscle relaxant. It is a smooth muscle relaxant. Okay, next is fallopian tubal motility. Estrogen increases the tubal motility, whereas progesterone relaxes the tubes also because of its smooth muscle relaxant property. It relaxes the tubes, predisposing to what? I already told you this important point. Yes, it relaxes the tubes, predisposing to very good ectopic pregnancy. So it increases the risk of ectopic pregnancy. Progesterone increases the risk of ectopic pregnancy, and that is why whenever you put the lady on progesterone only contraception, like progesterone only pills or implants, there is increased risk of ectopic pregnancy. Okay, now coming to duct. What does estrogen do? What does progesterone do? Estrogen helps the duct and stroma proliferate. Okay, estrogen helps in the proliferation of duct and the stroma. Whereas progesterone helps in the proliferation of the glands. Okay, progesterone helps in the proliferation of glands. You understand, no? Or the acini. Okay, so which hormone out of the two increases milk secretion? Which hormone out of the two increases milk secretion? Yes, estrogen or progesterone? Very good, progesterone. Okay, estrogen decreases the quantity of breast milk. Okay, whereas progesterone increases the quantity of breast milk. Estrogen and prolactin are opposite to each other. You understand? Estrogen and prolactin are opposite to each other. Estrogen decreases the quantity of breast milk, whereas progesterone increases the quantity of breast milk. So for a lactating mother who is in need of hormonal contraception, what is the contraceptive of choice for a lactating mother? You tell me. Contraceptive of choice for a lactating mother: DMPA, POP. No, I'm not asking what is the hormonal contraceptive of choice. I'm just asking what is the contraceptive of choice for a lactating mother. Very good, Vivekanandan. IUCD is the correct answer. Okay, IUCD is the perfect answer. Okay, but if there is any contraindication for IUCD and if she wants hormonal contraception, if she is a candidate for hormonal contraception, then your answer will be progesterone only pills or DMPA. Okay, so DMPA increases the quantity of breast milk. Now coming to liver. Okay, estrogen and progesterone, both of these hormones are thrombogenic, but which is more thrombogenic? Both of these hormones are thrombogenic, definitely. Which is more thrombogenic? Excellent, estrogen. Okay, so I have already explained what it does. No, it increases the synthesis of clotting factors. It inhibits fibrinolysis. Okay, it inhibits fibrinolysis, and altogether it increases the risk of thrombosis. It increases the risk of thrombosis. Progesterone also does the same, but is not as dangerous as estrogen in this aspect. Okay. Now coming to body temperature, which hormone increases the body temperature? Progesterone. It increases the body temperature by 0.5 degrees Celsius. It increases the body temperature by 0.5 degrees Celsius, which is a sign of ovulation. Which is a sign of ovulation. So you all understand, no? So these are the functions of estrogen and progesterone in different body tissues. Okay, functions of estrogen and progesterone in different body tissues. Okay. Now coming to signs of ovulation. Okay. Regular cycle versus irregular cycle. Which is a sign of ovulation? Tell me. Regular cycle or irregular cycle? Which is an ovulatory cycle? Yes. Regular cycles are ovulatory. Okay. And likewise, dysmenorrhea is a sign of ovulation. Primary dysmenorrhea. Primary dysmenorrhea is a sign of ovulation. I'll tell you what is primary dysmenorrhea, what is secondary dysmenorrhea later. But for now, remember, primary dysmenorrhea is a sign of ovulation. Okay. Mid-cycle pain is due to ovulation, and that pain is called as Mittelsmarsh. Okay. Mittelsmarsh pain is due to ovulation. Okay. Due to ovulation. Likewise, there can also be bleeding during ovulation, which is not a heavy bleeding but a spotting kind of bleeding. Okay. So mid-cycle bleeding is also a sign of ovulation. So regular cycles, pain during menses, mid-cycle pain, mid-cycle bleeding. Next is basal body temperature. Basal body temperature increases by 0.5 degrees Celsius. Increases by 0.5 degrees Celsius after ovulation. After ovulation. So this is also a sign of ovulation. Disappearance of burning and disappearance of spin barkate are due to progesterone. Disappearance of burning and disappearance of spin barkate are due to progesterone. Okay, because progesterone makes the cervical mucus thick. Okay, it's because of thickening of cervical mucus. It's because of thickening of cervical mucus. Next is serum estradiol. See, serum estradiol increases prior to ovulation, as I already told you. Prior to ovulation, what is the serum estradiol level prior to ovulation? Quickly tell me. What is the serum estradiol level prior to ovulation? Yes, I told you, no? 200 to 300 picogram per ml per follicle. Okay, 200 to 300 picogram per ml per follicle. I want you to remember this per follicle, this word per follicle, because when we discuss ovarian hyperstimulation syndrome, you will apply this. 200 to 300 picogram per ml per follicle. Serum progesterone. So this actually does not confirm ovulation, because this is a clue which you get before ovulation. So out of the signs that we have mentioned here, signs of ovulation, some signs occur prior to ovulation and some of them after ovulation, some of them at around ovulation. Okay. Serum progesterone, again a serum progesterone level of more than 4 nanogram. More than 4 nanogram per ml is a sign of ovulation. Is a sign of ovulation. Next is urinary LH. Okay, urinary LH. You tell me, when does urinary LH reach its peak? How many hours prior to ovulation? I mean, when does serum LH reach its peak? How many hours prior to ovulation? 12 hours. That's when it appears in the urine. Okay, so urinary LH is positive 12 hours prior to ovulation. 12 hours prior to ovulation. Okay. Next is ultrasound change. Okay. Listen. See this. How do we first of all identify that it is an ovary? Ultrasound image of the ovary with the follicles. How does the follicle look? Follicles are anechoic spaces. Follicles are anechoic spaces, like what you see here. Okay, follicles are anechoic spaces. Okay, black spaces. Now in this image you can see multiple anechoic spaces each of which is a follicle. Okay, among the follicles that you see here, one follicle is bigger than the other follicles. Okay, and that follicle is the dominant follicle for this cycle. This follicle is the dominant follicle for this cycle. You understand? Other follicles are all follicles which have tried to grow, but once one follicle becomes dominant follicle, the other follicles get suppressed. And after this dominant follicle ruptures, all other follicles which have already been recruited will degenerate. They'll all degenerate. You understand? So whenever we put a probe, a transvaginal or a transabdominal probe, and see the ovary, it is with the help of these follicles that we identify that it is ovary. And secondly, okay, it is with the help of follicles that we identify that it is ovary. And secondly, see, more the number of follicles you see in ultrasound, more the ovarian reserve. You understand? So this is called as antral follicular count. Antral follicular count. Antral follicular count is the number of follicles we see grossly in ultrasound. Whenever we perform an ultrasound, the number of follicles that we see grossly is antral follicular count. Okay, antral follicular count is nothing but the number of follicles seen at any point in ultrasound. Okay, number of follicles seen in ultrasound. Okay, so more the antral follicular count, more the ovarian reserve. Lesser the antral follicular count, lesser the ovarian reserve, which means antral follicular count can be used as a marker of ovarian reserve. You understand? Okay, so now listen, you know that the hormone that recruits follicle is FSH, no? Yes. On an average in a cycle, how many follicles do we recruit? You all tell me. On an average, in any given cycle, how many follicles do we recruit? In any given cycle, on an average, how many follicles do we recruit per cycle? Yes? Per cycle. Yeah. Around 20? 20? Why you people are interested in this number 20? Okay, let me tell you. We recruit around 1000 follicles per cycle. Okay, 1000 follicles per cycle. Okay, is what we recruit. Okay, out of these 1000 follicles, only few 10 to 15 follicles are seen in ultrasound, out of which only one becomes dominant. One becomes dominant and ruptures. One becomes dominant and ruptures. What will happen to all other follicles? All other follicles which have already been recruited. What will happen? When one follicle becomes dominant and that ruptures, what will happen? They'll all degenerate. Okay. Rest all degenerate. Rest all degenerate. So follicular depletion is at the rate of 1000 per cycle. Is at the rate of 1000 per cycle. Which hormone is responsible for follicular recruitment? Which hormone is responsible for follicular recruitment? FSH. FSH. So listen, follicle stimulating hormone is a dangerous hormone. It's a dangerous hormone. It's a double-edged sword. It's a double-edged sword. At one end, it makes the follicle grow. Okay, it helps the follicle grow. Okay, and help the lady get pregnant. Okay, help the lady get pregnant. So it increases the chance of pregnancy. On the other hand, it depletes follicles. It depletes follicles at the rate of 1000 per cycle. 1000 per cycle. So the more FSH you have, the faster you deplete. The more FSH you have, the faster you deplete. As age advances, no, FSH keeps increasing. FSH, because estradiol keeps decreasing. No, as age advances, your ovarian reserve decreases. Estradiol keeps decreasing. FSH keeps increasing. So the number of follicles you recruit from the ovary also keeps increasing. And of course, the depletion, occurs at a faster rate. For older women, the depletion occurs at a faster rate. You understand? So FSH is a double-edged sword. On one side, it helps the follicles grow. On the other side, it depletes the follicles. Okay, so what we do is, in any given cycle, in case a lady comes and she's had a long period of infertility, and now she wants to know whether she's ovulating or not. Okay, what we first do is, subject her for a transvaginal ultrasound study, see all the follicles in the ovary, and see whether the number of antral follicular count, see whether the antral follicular count is okay, adequate for her age, and then ask her to come for serial ultrasound, like say on day 10, day 8, day 10, day 12 of the menstrual cycle. Gradually the follicles will increase in size. So it will be small and then become big, and at that one point become big, and at around 20 mm, what we do is see whether she's spontaneously rupturing or not. If follicles are not spontaneously growing, for the follicles to grow, we give ovulation induction drugs. Okay, like clomiphene citrate, FSH and letrozole. Clomiphene citrate, letrozole and FSH. Don't have to worry about not writing this, because we have drugs for ovulation induction separately. We will discuss there. And at one point, when the follicle has reached, with the help of these drugs, for example, if the follicle has reached a size of 18 or 20 mm, we'll help them rupture. No, what do we give to help them rupture? Come on, tell me, what do we give? We give an injection to help them rupture. Very good. We give them HCG. Very good. We give them HCG. Okay, so for them to rupture, we give what? HCG. Okay, for them to grow, we give ovulation induction drugs. For them to rupture, we give HCG. Okay, and after they rupture, the fluid inside will be released into the pouch of Douglas. So free fluid in the pouch of Douglas can be taken as a sign of ovulation. Free fluid in the pouch of Douglas can be taken as a sign of ovulation. You all understand, no? Okay, the last is endometrial biopsy. Endometrial biopsy. Okay, don't disappoint me. Tell me 2 important findings in endometrial biopsy which will prove that she is ovulated, which will prove that she is in the secretory phase. 2 important findings in endometrial biopsy. Corkscrew glands and basal vacuolation. Fantastic answer. Okay, fantastic answer. 2 important histopathological signs, histopathological evidence of ovulation is corkscrew gland and basal vacuolation. Corkscrew gland and basal vacuolation. You all understand? No? Now I will ask you few important questions. You have to give me answers. Are you all ready? Okay, very good, Janani and Anma. Okay, listen to my question. Let's say there's a lady who's married since last 6 months or 1 year, recently married. Okay, living with husband. She wants to conceive. She's regular cycles, young patient, thin patient, no high risk factors, eligible couple. She wants to conceive, and she has some knowledge about ovulation and fertile period. She comes to you asking whether she is ovulating or not, whether her cycles are ovulatory or not. You get some basic history, and with the history you think that she is ovulating because she has regular cycles, painful cycles, and she's a thin patient, young patient. There's no other negative history. Okay, but she is unhappy. She wants to know for sure that she is ovulating. She is not in need of ovulation induction drugs. She is not in need of ovulation trigger drugs. She doesn't want to time the intercourse now because they are in regular intercourse. Okay, she only wants to know for sure that she is ovulating. Her cycles are ovulatory cycles. Okay, so which of the following investigation will be ideal for this lady? Okay, I'll give you options. Options are urinary LH test, serum progesterone test, endometrial biopsy, and ultrasound. Serum progesterone, urinary LH, endometrial biopsy, and ultrasound. USG, LH urine. Oh, nobody is giving the answer that I am expecting. Listen to me, I'll tell you something. I'm not for urinary LH here. I'll tell you why. Okay. I'm not for urinary LH here because urinary LH becomes positive only when the LH reaches its peak. And LH remains in the peak only for few hours. You understand? And if in order to exactly perform the urine test in this crucial few hours, you need to do several times. You need to do this test several times in a day. And usually this becomes positive in the late in the evening. You understand? So what we give the patient is a kit with 5 pieces in it. Okay, so we'll ask her to get this urinary LH test done right from day 10 or day 11, depending on her cycles, day 10 or day 11, and we'll ask her to do it once every day, and at around 14th day we'll ask her to do it more frequently. You understand? So she has to get it done several times in order to catch that urinary LH, and even if she does it several times, there is a chance of missing it. Okay, so this is one disadvantage of urinary LH. The second is endometrial biopsy. Endometrial biopsy is an invasive test. No, it's an invasive test. She's just married, she's 6 months, she's healthy, she doesn't have any abnormalities. Okay, we don't have to go for an endometrial biopsy. Third one is, you said transvaginal ultrasound. I'll tell you something. Transvaginal ultrasound, okay, has to be done at least, for 3 or 4 days in a cycle, like say day 8, day 10, day 12, day 14, to monitor the follicle, to track the follicle, and at a point when it reaches a size of 18 or 20 mm, it will usually rupture. And even if it ruptures, you will not be very sure, you will not know for sure whether it's a follicle or a cyst that is rupturing. You understand, no? And also, she doesn't want to time her intercourse based on this. She only wants to know whether she's ovulating or not. You understand my point? So, we can go for a simple investigation, a basic investigation, which will confirm ovulation. Okay? What is the answer here? What is the answer here? Progesterone. Serum progesterone. Provided she is not taking any progesterone tablet by mouth, you can measure progesterone in the second half of the menstrual cycle, and I prefer doing it on day 22 because that's when progesterone will be at its peak, no? So I prefer doing it on day 22. That's what the book says. And if progesterone levels are more than 4 nanogram per ml without any oral supplements of progesterone, it's kind of natural progesterone because she's ovulating. You understand, no, all of you? Second scenario, I'll tell you. Second scenario, okay. A lady comes, primary infertility, okay. And so you have basically done all investigations. All the investigations seem to be normal. And it's kind of an ovulatory cycle. It appears to be an ovulatory cycle with her history. Okay. And now after testing the female partner and male partner thoroughly, I assume that the infertility is due to improper timing of the intercourse. So maybe they have no idea on what a fertile period is and what the safe period is, and so they are not able to time the intercourse properly. And I will now want to give her those golden hours for intercourse. You understand? I will now want to give her the golden hours for intercourse. You understand? Okay, in that case, what can I do? If you want to exactly pick those golden hours, transvaginal ultrasound. Anashwara says transvaginal ultrasound. LH, serial ultrasound. So competition goes between transvaginal ultrasound and LH, no? Okay, listen. Out of these two, which is more accurate? Ultrasound has a false positive rate of plus or minus 2 days. If supposing today it's 18 if the size is 18 mm, she can either rupture the follicle today or tomorrow or day after tomorrow. We do not know. So rupture can occur anywhere between 16th day and 16 mm and 24 mm. So it's kind of variable, plus or minus 2 days is there. But LH does not have that long variability. No, it's more accurate, more precise, and exactly 12 hours from the positive urinary LH test she'll ovulate. So most accurate to time the intercourse is most accurate LH. You understand? But urinary LH is not what we most commonly do. Okay, what we most commonly do is transvaginal ultrasound. And overall best is endometrial biopsy. So here I have 4 questions. The first question was asked in INI-CT 2021. INI-CT 2021. The second question was a DNB question. Very old DNB question. The last 2 questions are likely to be asked, will be asked very shortly. Okay. First question is simplest investigation. Quickly give me answer. Simplest investigation to confirm ovulation in women with regular cycles. Come on. Quickly give me answers. Serum progesterone is the perfect answer. Serum progesterone. Very good. Very good. Very good. Okay. Next question is overall best method to confirm ovulation. Most definitive and best. Overall best method to confirm ovulation. Very good. Endometrial biopsy. Endometrial biopsy. Okay. Right. Next question. Most commonly used technique to track the follicle or to time the intercourse in infertile women. Which one do we more commonly use? Most commonly used to time the intercourse? No, LH is not the most commonly used. Ultrasound is the most commonly used. Okay. LH is not the most commonly used. Ultrasound is the most commonly used. Transvaginal ultrasound. Transvaginal ultrasound. Okay. Most accurate clue is LH, or best clue is LH. Okay. So best clue of impending ovulation is urinary LH. Urinary LH. You all understand? No. The best clue of impending ovulation is urinary LH. Okay. So these are keywords. Basically, you have to remember keywords. Here the keyword is best clue of impending ovulation. Impending. She's going to ovulate. Okay. To track the follicle. To track the follicle, it's ultrasound. Okay. Or to time the intercourse, it's ultrasound. Of course, here LH can also be used, but most commonly used. TVS. Is it okay? Last few points on anti-Mullerian hormone. Anti-Mullerian hormone. Okay. Anti-Mullerian hormone is secreted by the granulosa cells. Granulosa cells of the ovary. Okay. Anti-Mullerian hormone inhibits the development of Mullerian duct in males. Mullerian duct in males. What does it do in females? What does anti-Mullerian hormone do in females? Anti-Mullerian hormone opposes FSH. Anti-Mullerian hormone opposes FSH and decreases FSH mediated follicular recruitment or follicular atresia. It decreases FSH mediated follicular atresia. Anti-Mullerian hormone is not only secreted by the growing follicle or the mature Graafian follicle, it is also secreted by all the resting follicles. Secreted by growing as well as resting follicles. Resting follicles. Whereas estradiol, inhibin and other hormones are mainly secreted by the growing follicle, right? Okay. So when a hormone is secreted only by the growing follicle, we may not be able to, assess the ovarian reserve properly, because only 1 or 2 follicles grow and reach the adult size, all other follicles degenerate, so we may not know how many follicles are in the resting phase. But when we have a hormone which is also secreted by the resting follicles, and when we measure it, we get a clue on how many follicles are there in the ovary and what is the ovarian reserve. So please remember, anti-Mullerian hormone is the best marker of ovarian reserve. Anti-Mullerian hormone is the best marker of ovarian reserve. Best marker of ovarian reserve. Very important MCQ. Okay. Whereas the best marker of menopause is FSH. Okay. The best marker of menopause is FSH. The best marker of menopause is FSH. The best marker of ovarian reserve is AMH. AMH. Next question is, if AMH is not there, what will this FSH do? FSH will recruit more follicles and the ovaries will deplete at a faster rate. You understand? If AMH is not there, the cycles, instead of being monofollicular, would become multifollicular. You understand? So in the absence of AMH, follicular FSH mediated follicular depletion will increase. Okay? In the absence of AMH, cycles would become multifollicular cycles. It is only because of AMH. Because AMH controls the action of FSH. No, if AMH is not there, instead of recruiting 1000, in place of 1000, the FSH would recruit 2000, 3000. So obviously the follicular depletion will increase. So it is AMH that makes the cycle monofollicular. Okay, monofollicular. So two questions are there. Which hormone is responsible for follicular development? It is FSH. Which hormone is responsible for monofollicular development? It is AMH. If you see this word monofollicular, your answer should be AMH. You all understand? This is about menstrual cycle. Do you all understand? Give me thumbs up. Yes? Ferning spin bucket. Very good. Let us see some questions. Okay, ma? Granulosa cells secrete all except. Come on. Granulosa cells secrete all except testosterone. Correct. Testosterone is secreted by the theca cells. Right. LH surge is due to. A. Right. Positive feedback effect of estrogen. Right. Third question. Spin bucket is due to. Again one. A. Thinning of the cervical mucus due to estrogen. Right. So tell me, thinning of the cervical mucus or thickening of the cervical mucus, which is actually a sign of ovulation? Thickening. Thinning can also be taken as a sign of impending ovulation, but what confirms ovulation is thinning followed by thickening. Okay. Size of the dominant follicle is. All the given answers are actually correct, but the most appropriate answer is 20 mm. Polyspermy is prevented by, you all know what is polyspermy? Give me answers later, I'll explain. Polyspermy is prevented by zona reaction, right? Zona reaction. Okay, what is zona reaction? Zona reaction is also called as Ullima block. Zona reaction is also called as Ullima block. Ullima block, in which zona reaction is also called as Ullima block, in which zona becomes hard after fertilization. Zona becomes hard after the entry of one's sperm after fertilization, which prevents the entry of multiple sperms. Type of epithelium in the ectocervix. Ectocervix. Squamous. Squamous, right. Next question, levels of estradiol prior to ovulation. Again D, very good, very good. Okay, which type of estrogen is specific for pregnancy? Which type of estrogen is specific for pregnancy? C, very good, estradiol. Estradiol. pH of the vagina in the reproductive age group. Reproductive age group, D ma, D. Reproductive age group, it's 4 to 5. Okay. Why Rohita you're marking 1? Is it 6 to 7 in the reproductive age group? It's 4.5 to 5.5. In the given options, 4 is the best answer. Type of oocyte in the newborn ovary. Newborn ovary. Primary oocyte. Right. Primary oocyte. In a 28-day menstrual cycle, peak activity of corpus luteum is seen on. Peak activity of corpus luteum. Day 22. Perfect answer. Perfect answer. Day 22. False statement regarding hormonal status in a postmenopausal woman. Postmenopausal woman. Which is wrong here? Very good. Decreased FSH is wrong. Okay. After menopause, estrogen and progesterone decreases, which leads to increase in FSH and LH. Increase in FSH and LH. In fact, this is the best marker of menopause. Best marker of menopause is what? FSH. And of course, premature ovarian failure is also FSH. Best marker of ovarian reserve is AMH. Okay. You know what is bar body, no? Bar body is number of X minus 1. So bar bodies are not seen in Turners. Right. XO, Turners. The earliest morphological evidence of ovulation on endometrial biopsy is? Which is the first sign of ovulation in endometrial biopsy? B. Right. Basal vacuolation. Correct. In a 40-day menstrual cycle, ovulation occurs on 26th day. Right. 40 minus 14. 26th day. During pregnancy, which hormone maintains corpus luteum? During pregnancy, which hormone maintains corpus luteum? HCG. HCG maintains corpus luteum. LH surge precedes ovulation by? LH surge precedes ovulation by? Yeah, ma. Why are you marking 12 hours here? LH surge, not LH peak. 36 hours is the correct answer. Dinesh and Vashiha. 36 hours is the correct answer. I think you marked it wrong, out of hurry. Correct? Hormones increased in females after menopause. Okay, leave it. Gonadotropins are elevated after menopause and remain so for how long? For how long? Very good. Very good. Rest of the life. Right. Okay, leave it. This is day 21. When should the serum progesterone test be done to confirm luteal phase deficiency? This we are not doing now. Okay, we used to do serum progesterone test and endometrial biopsy to diagnose luteal phase deficiency. Luteal phase deficiency means inadequate progesterone. Luteal phase deficiency means progesterone deficiency. Luteal phase deficiency means progesterone deficiency. So to diagnose this luteal phase deficiency, we used to do serum progesterone test and endometrial biopsy on day 21 or day 22. On day 21 or 22. But we are not doing all of these now. We are not doing these now. Okay. Instead, we are directly supplementing with progesterone. Whenever you, what are you going to do after measuring serum progesterone, after doing endometrial biopsy? If you diagnose it to be luteal phase deficiency, you are anyway going to supplement progesterone. So why do you perform an invasive test on a pregnant lady or a lady who's trying to conceive and then supplement progesterone? Rather, you can directly supplement progesterone. That's the idea. We are not doing these tests now. Okay. Maximum function of corpus luteum is on here the 9th day, usually the 8th day post ovulation. Here the 9th day. Normal pH of the cervix. Give me answers. Normal pH of the cervix. Cervix is acidic or alkaline? Vagina is only acidic. Cervix is 8 is the perfect answer. Vaishiha is correct. 3 is wrong, ma. Rohita, 3 is wrong. 8 is correct. pH, cervix is alkaline. Cervix is alkaline. When we discussed fertilization, I told you capacitation occurs in the cervix and not in the vagina, because vagina is acidic, cervix is alkaline. So sperms will not survive for more than few hours, say 3-4 hours in the vagina, whereas in the cervix, because it is alkaline, it can survive for 2 to 3 days. Yes or no? Didn't I tell you? Did I tell you or not? Nama, Rohita. Corpus luteum function is taken over by that's 12 weeks. That's all known, no? Ferning is due to which hormone? Ferning is due to right. Yeah. Estrogen. This is repeating one thing. This question, see this question. Features of a post-ovulatory endometrium on ultrasound. Post-ovulatory endometrium on ultrasound. I didn't tell you this, but you make a guess, no? Features of post-ovulatory. Question number 29. Okay. I'll tell you something. Pre-ovulatory endometrium only shows 3-line sign. Uterus is like this, no? Yes? This is 3-line sign. The anterior wall of the endometrium, this is the thickness of the anterior wall. This is the thickness of the posterior wall. But when we measure the endometrial thickness, we'll measure both the anterior and the posterior walls together. Endometrial thickness means it's a combination of both anterior and the posterior walls. You understand? This is 3-line sign. This is pre-ovulatory. Pre-ovulatory 3-line sign. After ovulation, it becomes compact. It becomes one single unit. Okay, it's like this. After ovulation, it's like this. Okay, correct answer here is loss of 3-line sign is okay. Single hyperechoic line is also okay. That word thin is not appropriate. Loss of 3-line sign is perfect. Loss of 3-line sign is perfect. Triple line endometrium is seen in question number 30. Triple line endometrium is seen in pre-ovulatory. Pre-ovulatory. Okay. Which of the following statement about inhibin is false? It keeps coming. Where is it stopping? Okay. Which of the following statement about inhibin is false? Yes? Inhibin B is secreted in the follicular phase. That's right. That's right. Why? What is the question asking? The question is asking the false statement. No. Listen, inhibin B comes in the first half of the menstrual cycle, in the follicular phase. In the follicular phase. Inhibin A comes in the second half of the menstrual cycle, in the luteal phase. I kept on telling no that corpus luteum secretes inhibin A, corpus luteum secretes inhibin A. Okay. So you got it clear, Vashiha, now? Inhibin B in the first half by a pre-ovulatory follicle. Inhibin A in the second half by corpus luteum. Okay. So option 1 is wrong. Inhibin A is secreted in the follicular phase is wrong. This is wrong. All others are correct. All of the following are used for treating spasmodic dysmenorrhea except. What is the answer? Spasmodic dysmenorrhea. Misoprostol will in fact increase the pain, no? In a clomiphene-induced cycle, which of the following can be given as an ovulation trigger? HCG can be given, GnRH can also be given. This question has 2 correct answers. GnRH agonist can also be given as ovulation trigger. Okay, this question has 2 correct answers. Okay, what we commonly give is HCG. GnRH should not have been there. I will tell you when we discuss infertility. But here the answer is HCG. It's a typo error. Pulsatile GnRH is used for treating which of the following conditions? Okay, you tell. So ABD, ma'am, what is that? What are you asking? It's my mistake that I typed it wrong. Okay. GnRH agonist. GnRH agonist can be used for trigger. It should have been GnRH antagonist. The last option should have been is GnRH antagonist, and in that case FSH would have been the answer. ABD. B is FSH, no? FSH we don't use for ovulation trigger. FSH is used only for the follicular growth, not trigger. HCG can be used for trigger. HCG can be used for trigger. GnRH agonist can also be used for trigger, because when you give GnRH agonist, no, LH levels, endogenous LH levels increase. This can also be used for trigger. FSH is used only for ovulation induction, which means for the follicles to grow. See this question. What is the effect of pulsatile GnRH on the pituitary and pulsatile GnRH or continuous GnRH? Which one stimulates the pituitary, you tell me? Pulsatile GnRH or continuous GnRH? Which one stimulates the pituitary? Pulsatile GnRH stimulates the pituitary. Continuous GnRH inhibits the pituitary. Pulsatile GnRH inhibits the pituitary. Pulsatile GnRH stimulates the pituitary. Precocious puberty, fibroids and DUB are high estrogen states. These three are high estrogen conditions in which we require continuous GnRH. Okay, treat them with continuous GnRH. For infertility, we need more FSH, so give pulsatile GnRH. We need more FSH, no, for the follicles to grow, so you give pulsatile GnRH. Is it okay? So here we finish menstrual cycle. Do you all understand? Do you all understand? Yes, this topic? Very good. Okay.